Excellent. Okay. Now, we've already had one question, which I'd like you to repeat if you would, and then we will carry on and get another couple of questions, particularly if there's one that Michael's talk has sparked for you. So, again, reintroduce yourself quickly. Give us the question.
I'm Catherine Taylor from Ovarian Cancer Action, and my question is particularly for Dominic, but you gave us the example of the Robert Jones patient and how all that information could be captured on the smartphone. And I'm wondering whether there are any hospitals or healthcare systems internationally that do this well that we could learn from.
Thanks for the question, Catherine.
Can I just, well, I'll just take another couple of questions as well. There's a question there, and then there's going to be a question over there. So if we can get that.
Thank you. It's Paul Breckle from the charity Action on Hearing Loss. It was really a great question to the whole panel, but I guess in particular to the first two speakers. Sorry, Michael, as my question came before your fantastic talk. Just about sort of internal barriers, really, so and how you overcame them, both whether from a Parkinson's perspective in terms of moving the charity on, or from a DeepMind perspective in terms of when you're working with the NHS or other partners, and sort of what were the things that sort of really sort of brought digital transformation to life for maybe the folk that are a little bit behind the curve internally. Fine.
And our final question of this round?
Liam O'Toole from Arthritis Research UK. I've got a question for Julie. Emma's story was inspirational, and I just wanted to know, does the Emma Watch work for everybody with Parkinson? And how close are you to getting it to everybody who needs it?
Okay. Over to you two.
So first to Catherine's point. So I should say that product that I showed you is now working in undergoing an evaluation at the Royal Free Hospital, not very far from here. I think we beat ourselves up in the UK and in the NHS around kind of digital transformation, which is a function of like us all wanting to improve things, but actually if you look outside the UK, there are some hospitals and organisations that I think are a little bit ahead of us, but there's no nirvana out there at the moment as far as at least I'm concerned. So people that are doing really interesting things, Mayo Clinic, as you may imagine, so there's a lot of good stuff that they're doing with clinician access to apps that, you know, they tell a great story about how their clinicians say that their lives have been transformed because they can have breakfast with their kids, and while they're having breakfast with their kids, they're able to look at their 10 patients' lab results and not be rushing in or trying to, you know, phone up and find out what the results are. They've also got a patient portal, and I think that's generated or stimulated a lot of other competing hospitals like the Cleveland Clinic and others to provide similar services. So I think things are a little further ahead in like some of the big US centres, but a lot of them are facing exactly the same challenge as we are, which is hundreds of different systems that don't speak to one another, very high barriers to entry for innovators, and that kind of touches on the point of the second question from my perspective in terms of the big barriers. There are major kind of problems in the current setup of systems, whether it's been primary care, secondary care, the products that innovators are developing. And I think there's, for the first time, real change and movement taking place where everyone's working towards the same interoperable open standards that will allow different systems to speak to one another. And when that's cracked, which, you know, there's huge enthusiasm to do in the NHS, things are going to like totally transform and allow, for example, a Parkinson's product and the data that collects to feed into the patient record, the data that your watch is collecting. You know, for example, I think step count is an amazing metric that all of us, if you didn't know, look on your phone now and it will tell you how many steps you've taken every day over the last year. That's gold dust to a medical record potentially. So it's becoming much more realistic that all these things are going to start speaking to one another, which opens things up tremendously.
If I can, I'll try and give an answer probably to both questions, and I don't know whether you want to add to it, Dominic. So on your question about overcoming the barriers, there are lots and lots different things in the way of this in organisations like Parkinson's UK, and none of them are intended. They're all because people are committed to other really important work that we know, that we have data that does work already, because people aren't really sure exactly what this means tangibly enough to know how to act on it. There's lots and lots of those things, and coming into a role like mine, it's a bit intimidating to work out what buttons to push and when to push them. But a few things just happened, really. Almost before I arrived, as soon as the charity said, right, digital transformation is something we're putting at the top table, something seemingly happened, the people have told me, before I got there anywhere near it, where it was like people had been given permission to talk about things that they were already thinking. And since I have arrived, I've come across any number of colleagues across all of our different departments who are technology enthusiasts, who have lots more experience than I do in different areas of it, that have done technology-based work in previous roles and have been quietly frustrated by not being able to do it. So a lot of it is just about that kind of permission point, actually. Making a statement that this is important. That statement I put up about, we are going to use digital technologies to help people affected by Parkinson's. Oh, are we? Okay, great. British Red Cross has done something similar with their strategy. They've said if their overall mission is to help people in crisis, one of their 6 strategic pillars is use technology to help people in crisis. There's something about that statement that makes a big difference. Then there's just an awful lot of talking and smiling and examples. Talking and smiling and examples is probably 50% of my work, and trying to bring other people into those conversations. But really, it's there are so many people in all of our organisations who already get this and want to do it, and I think the permission point is the single biggest one. Happy to have a follow-up conversation about more of the specifics of what we're doing, because it's so much about confidence as well. Confidence.
I agree completely on that. And smartphones are such a I'm not sure that's the right term, democratizing technology. I will confess to being the least technologically sophisticated person that works in this building. I've never coded. When the smartphone came out, it was the first time that I actually thought, oh, this is something that, has gone on, as all of us know, to change the way we do all kinds of things. And I think the reason why there's enthusiasm from people that wouldn't consider themselves to be technologically sophisticated is that they're used to doing so much stuff in their phone now, and it just makes sense to them. Just to bring Michael on this, as a general surgeon in the NHS for over 10 years, as what Michael says about the outputs of a stoma bag, that information is so valuable to what we used to do on a day-to-day basis, and we never had access to it. When we're at a point where we can bring Michael's technology and hundreds of other technologies into this wide ecosystem, I really do think care is going to be totally transformed. But there are a few barriers to get there, and I think there's a huge place for patient innovators and charities, with the trust they have from patient groups, to be delivering a lot of those patient-facing platforms.
I'd agree with that, and I think one of the key drivers for me of this it is what we've seen in the last 5 years, is patient and public demand for this growing very rapidly. And it really, frankly, it was not there when everything was desktop based. There really wasn't that push to get clinicians, to get healthcare staff, and to get the investment required that there now is. And I think charities have a real role in creating that patient pull that wasn't there previously. And when you look back, before the change happened at Parkinson's, I'm sure that basically many of in our working lives 5 years ago, 8 years ago, IT was cumbersome, it was desk-based, it was the IT's department. And certainly getting significant investment into getting the websites up and running and so on was really tough. If you were balancing that against, say, from my experience at Terence Higgins Trust, because we're a service providing organisation rather than a research one, do you provide more counselling sessions? Or do you invest in the web? How do you do both? So, and that's a real problem for hospital trusts and across the NHS and within GPs as well. So, but I'm convinced that now all of us are using our smartphones and they are so intuitive that patient demand will create change. It has to. Michael, anything you want to add?
Yeah, just wanted to add one point to this. Charities and patients like me, well, patients like me as an organisation and patients like myself, can create adoption outside the system. Quite simply, you know, we can build systems for our patients, for charities. The moment you want to interact with the healthcare system, one of the barriers that you have to discuss at some point is money, whether we like it or not, and who's going to pay for that technology. Is an app going to be prescribed, for example? And one of the challenges in the NHS that we have that we don't necessarily have in the US is there's no joined up money line in the NHS. So in other words, something that may get started in secondary care and then moves to primary care, that might move to social care, who pays for that? Now, there's one thing if you say the consumer is paying for it, but if you expect the NHS to pay for it, and I think at the moment that's the vast majority of the public, that's a real challenge. In the US, obviously, for all its faults, you have insurance. And if insurance covers that technology, which they do in my particular case, it doesn't matter where you are in the system, you're going to get reimbursed for the technology. So I think, you know, building solutions outside of an interaction with the NHS allows you to get greater patient pull and adoption. The moment you want to interact with the system, sadly, money does come into it, particularly at the moment.
I'd absolutely agree. Certainly our experience at Terence Higgins Trust when we set up My HIV, which encouraged people living with HIV to put in their own data about their CD4 count, their viral load, their medications and so on, and create their own patient record in essence. And together with a whole range of other options of putting down the questions I must ask my nurse next time I see her, or my consultant next time I see him or her in 6 months' time. All of that we knew would have benefits to the NHS, but we could not get funding because funding is devolved down now across actually in HIV world to local authorities. And commissioners there, first, you don't have the money, and secondly, knew full well that if they didn't fund that, which they knew would benefit their residents, we would deliver it anyway. So we're in that bind, and I'm sure many of you will have similar stories of how do you fund a generally wide open and easy access process, which hard-pressed commissioners will know you'll deliver anyway. It's a real challenge. One quick thing, Liam's question, do you want to pick that up?
So the slightly disappointing answer to that question about Emma's watch is the answer is no. It's bespoke made for Emma, and in its kind of current form, it only really works for Emma. It helps other people, but it is really finely tuned. So the conversation that we're having is about how quickly and how, I guess, cost effectively it could be adapted and manufactured. Now, it may well be that conversation turns into this is a no-go. We're hoping not. There's an engineer in Wales who Microsoft have given the technology to, and he's exploring, because ideally what you want is a device that you can tweak yourself to get it to work for you, who's looking at that. We're quite early stages, we're hopeful, but no, it's a long way from being a market-ready product at this stage, which is hugely frustrating to a lot of people with Parkinson's who've got in touch to say, can I have one and can I have it now?
Okay, we've got a couple of minutes more. I'm letting this run on till just gone 11:15 to allow the 15 minutes we were delayed. So a couple more questions. One here, I've got one as well, and one here. So us three then. You, sir? Or who's got the mic first? Oh, we've got the mic first over here. So off you go.
Hello, I'm Anna Beukenhorst from the University of Manchester. And I had a question to Michael and also the other members of the panel. So you all described very big wins, the DeepMind solutions, the Parkinson solutions, and the patient-fueled solutions. How can we all in this room proceed identifying these big wins?
Okay, thank you. And you, sir?
Hello, Paul Buchanan from Team Blood Glucose. Hello, Michael. I've got a question for you and to the panel. Do you think it would have been possible, Michael, to have created your solution and the question to you, Julie, about Emma's watch without the engagement of the patients driving the technology and seeking solutions through digital and social platforms and engaging that way? And what do you see as the barriers to utilising what I think was one of Michael's first comments about the underutilised and untapped resources that exist in patient populations?
Thank you. And Michael, I have a question for you as well, which is really just to pick up what you're saying about how free you are with your data. I'll share my data with anyone. As you know, I ran the Terence Higgins Trust for many, many years. And of course, talking to people with HIV and AIDS, there is a wide range of view about this, from those who absolutely agree with you, Michael, and took to the barricades in the 1980s, very open about their diagnosis, through to those who were really fearful of anyone finding out about their diagnosis, and that includes the rich and powerful. Freddie Mercury, for example, being diagnosed with HIV in the mid-1980s, did not worked incredibly hard to ensure that that remained confidential, through to many of our African clients who are really fearful that their living with HIV becomes known within their community or more widely. So, Michael, how do you bridge those concerns from those who feel that their health data is highly personal, highly confidential, with our mutually held desire to ensure that data is shared so that we can improve health and social care? So those three questions. Michael, do you want to start in, because a couple of the questions are directly for you?
So just to go to your point about the data, my starting point actually is quite simple. It's my data. I'm the patient. It's my data. I decide what I want to share and when I want to share it. So I'm completely respectful of an individual's choice to decide what they do or don't want to do with the data. But the decision lies with me as the individual, is my belief. And what I don't want the discussion to get clouded out with is all the headlines that go data breaches and the NHS are engaging with commercial partners and they're just going to sell your data, to cloud the fact that if you consent, as I do freely, to share my data, I want the right to do so. So for me, the starting point is quite simple. In reality, it's my body, my data. I consent to share it with my doctors implicitly, but sharing it wider, that's my choice. Paul, to your quick question is, I don't think it would have been possible for me to develop technology without the patients. In my particular area, which is, stoma bags and bags in general, there hasn't been innovation in that area for decades. And I think it takes patience to drive that change. I think adoption in the system, though, is very different. It's one thing to build a solution. There's another thing to get adoption of it. And you can't do that alone. And I learned that, the hard way. You have to interact with the system, and learning how to interact with the system is a real challenge for outsiders like patients, I think. So I don't know if that answers the two questions.
Thank you very much, Michael. That's really helpful. The big wins question. I'll take that up.
Yeah, thanks, Anna. So I guess it requires a shift in how an organisation thinks and priorities, as you wisely said. People have there's not a lot of money around anywhere at the moment, and so if you go down the digital journey, you have to do it properly, and I'd really kind of encourage people to avoid doing what I've seen in a couple of cases, which is putting small amounts of resource in, thinking you can do something meaningful, because it's really difficult to do. You need a head of digital, you need, as Lenny will talk about later, you know, there's a team of designers that now sit in a hospital at St. Mary's. If you walk around the floors here, there's designers all over the place. I'd question whether most of the charities represented here, for example, have any like designers or a head of design or a head of digital. That's the kind of thing that needs to be decided at very high level, and a shift in priorities from written information sheets to apps needs to take place, and recognize that that's actually, as you said about websites, we all have websites now, that's actually quite a big investment. That's not something that can be done cheaply or without resource.
Yeah.
Especially when you're going to make them, what was the phrase you used? You make them marvellous, or make them...
Delight.
Delight, yes. And we all need delight in our world. And we can now delight in having coffee, networking, talking to each other. And I'm going to cut that by 5 minutes, and we're running about a quarter of an hour late. So I would like to restart at 11:45. So there you go. Thank you. Could we thank our speakers for this morning for getting off to such a good and thoughtful start. So thank you, Julie, Dominic, and Michael particularly. Thank you for staying up so late. And I hope you managed to get a really good night's sleep, even though you're starting much later than I thought than you probably wished to. Michael, thank you all. Thank you very much.